Welcome to Medical Associates Health Check. My name is Dr. Laisha Selvaraja. I am the clinical administrator for Medical Associates, and I'm the head of accident and emergency. With me is my co-host.
I'm Dr. Bristol, and I am the founder of the Concierge Medical Clinic, and I'm a specialist physician in internal medicine.
So today we are going to talk about breast cancer. I guess my pink shirt gave it away. But we do have a very special guest. We have Dr. Liron Olivier, consultant breast surgeon. Thank you so much for coming on today.
Thanks for having me.
Well, could you tell us a little bit about your history and your background?
Yeah. My background started with a background of general surgery. So I did my residency in general surgery in University of the West Indies. And then during that time period, I always wanted to find a niche that I think I can make a change. And breast cancer was one of those niche that I think the country needed. And that's why I decided to pursue that. Fortunately, I was able to get a scholarship from the University of Toronto. So I did my specialist training, my fellowship training, postgrad in breast and breast surgical oncology.
Okay, and tell us about what you're seeing in terms of breast cancer in Trinidad and Tobago.
Internationally, we see now that breast cancer is the number one cancer in terms of incidence for women, as well as the number one cancer causing death as well. So in 2021, there was about 2.6 million women diagnosed with breast cancer in the world. And we had over 685,000 women died from breast cancer in 20. So that made that jump where breast cancer actually became the number one cancer for women. In Trinidad, in our small island, there is some data from between 2014 to 2016, a 5-year period, 2018, sorry, a 5-year period where we had roughly about 1,900 women diagnosed with breast cancer, and we had 1,100 women died from breast cancer.
That's a significant proportion.
It's very substantial. And if you look at that, break it down into per year, it's roughly about 500 women were diagnosed with breast cancer, and 275 women died from breast cancer.
So there's just over 50% that's dying, or the mortality rate is over 50%.
Again, mortality from breast cancer is heavily dependent on when it presents.
Right.
And presentation, it can be on a screening principle or it can be on a clinical principle. We will talk about the screening and how patients will present to breast cancer. But we know that if we pick breast cancer up early, the survival is significant. Yeah. So we have seen a significant reduction in mortality from breast cancer with screening. The past 10 years or so, it was accounted for about 20% reduction in mortality. But there's also an increase in pre-malignant cancer diagnosis as well. But generally, over the past year in 2023, we actually showed that screening for mammography, there was a 66% reduction in breast cancer.
Okay.
And that led to a new age group in terms of what we start screening for. But yes, we have seen more screening, but unfortunately, in Trinidad, we don't have a screening policy. So internationally, there are screening policies. When you reach a particular age, there's a system that will call you and send you an email saying you have to go to this fixed point to get a mammogram.
Right.
So, benefits now, but that's why Medical Associates will stand for as well, is screening, where patients will individually go for screening and have their screening done.
But Laron, now we're pushing for patients to screen even earlier
Yeah.
than what the older guidelines would have said.
Yeah.
We would have said about 50 before.
Yeah.
Now we want them to come in earlier.
Yeah, so earlier, before it was 50, when I first came back, I gave a talk. WHO was what we practiced in Trinidad was age 50. Now, as I said, from 2023, this paper was done by the radiologists, and they actually found that there was a 66% reduction in breast cancer mortality if they start at the age 40. Right. When you look at our breakdown, and that same data I was giving, between the age of about 30 to 40, is about 17% of our patients actually have breast cancer. The majority groups still anywhere between the age 50 to 60 is about 22%, 60 to 70 is about 20-something percent. But that age group, or let's say about 20%, that whole age group is being lost if we don't screen earlier.
Right.
So but we know that breast cancer is presenting earlier. That don't mean to scare. I have 25-year-old patients with breast cancer. I have 31-year-old with breast cancer, 26-year-old. And breast cancer is such an important element. Before we were talking about, families with breast cancer. Breast cancer touch women in every family.
Sure.
It can be a sister, it can be a mother, it can be a grandmother, it can be a cousin. I think everyone has met someone in their family who probably has some element of breast cancer.
Yeah. And in terms of, screening is one thing. We have specific tests that we would use, to screen these patients.
Yeah. So in I wouldn't say low resort countries, we generally will start even before screening. We start talking about clinical examination and self-breast examination. Unfortunately, those studies does not show that there's a reduction in mortality, but we know that there is a reduction in presentation in terms of you may present at an earlier stage.
Right.
And we know that there are 4 main stages in breast cancer, and they're all dependent on the size of the cancer and if the cancer has involved the lymph nodes. Obviously, the one that the cancer has gone beyond the confinement of the breast, that's where you call stage 4. That survival is worse. The survival for stage 1, a small breast cancer is 97 to 99%. Stage 2, there's lymph nodes involved, and that's the breast cancer in the breast alone is about high 90s, 92, 93. And then if you go into stage 3, it's about 70 something, and stage 4 is about 40%. So it's important for us to screen earlier.
We're talking about screening, and we seem to be only really touching women, but men get breast cancer too.
So, I wrote an article on it for True Medical Associates as well, where I wrote a paper about male breast cancer. Men do have breast tissue behind the nipple, though it may be smaller quantity. We still have the cells and the breast tissue that can change into cancer.
Yeah.
There's a thought process that male breast cancer is worse than female breast cancer. That's not really true, but men present later.
Right.
So, a guy might say, that's a little swelling, that'll go away. And by the time they present, because there's small residual amount of breast tissue, the cancer spreads more locally, quickly. So it tends to present at a later stage. And again, the later your stage in presentation, the worse the outcome.
Right.
So, we talk about how women can check themselves and examine their breasts. Is it this exact same process for men, or is there a different examination?
I mean, again, there's no fix. So what I tell my patients, patients are not clinicians, they're not physicians. What you want to do is to be aware of your breasts. So even in women, I will tell them every month, if you're pre-menopause, that you still have your monthlies, I would say 7 days after your period, you examine your breasts. They don't have to be in any particular order, but at least cover every quadrant of the breast. And I want you to be aware of your breasts. And again, the same principle applies with a man. When you're showering, you examine all the quadrants of your breast and just be aware. What you want is to find a difference, find a change. If you find something is different, then you reach the physician to clinically examine you, and then you do the necessary examinations.
You should also feel your armpits.
Yes.
Yep. So, this leading us down to a discussion now about how does breast cancer present. Breast cancer.
Before we go down into the presentation, right? I want to stop you there. We're going to take for a short break, right? So when we come back, we will get into the discussion about how breast cancer presents and what you should actually look for as a patient. So stick around. We'll see you soon.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates' gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, number 1 healthcare for the entire family.
Welcome back. So before we actually took the break, we were speaking about the presentation of breast cancer. Breast cancer is something that's actually pretty dear to me. My own mother suffered with breast cancer, unfortunately, with both breasts, right?
Yeah.
So it's something that women have to really pay attention to, men as well. But they all present differently, right? Not everybody would come with breast pain or thing. What are the variations that you would see in terms of the presentations?
So, we really want to pick it up even before it presents, but generally they may present, the common finding is a lump. It may be, and the most important point here is a painless lump. As humans, we believe that if something is not hurting, something is not wrong.
Right.
Unfortunately, breast cancer is such a disease that it may present without pain. I'm not saying that it can't have pain. 3 to 4% of breast cancer lumps could become painful, but it tends to be when it's more advanced, when it starts involving the chest wall, the muscle, the skin, involving the nerves to the area. It might cause some discomfort. Generally, I have a lot of patients that will come in and say, Doc, well, I had that lump that wasn't causing me any pain at all, so I was not worried about it. And again, the longer you wait, the bigger it gets. Greater chance of it spreading to the glands under your armpit, the greater chance of it pouring into the bloodstream, going to areas like your lungs, your liver, your bone. And that's where it becomes difficult to cure. So we want to pick it up. So once you find a lump, again, we want to investigate it. So a breast lump, that lump may be firm, it may be regular. Generally, if it is felt before, let's say you normally have your monthlies and you feel it during your period of time, it may be just a cyst or what have you. But what I would say, if you're waiting for your monthlies, you wait at least probably a month, one cycle. If it persists, seek consultation. However, if you're post-menopausal, meaning that your menses has stopped, if you have any lump, don't wait any time, because you shouldn't have a lump after that period of time. So those are key points that we have to discuss, and those are things we have to keep saying over and over. So a breast lump, you can also get a nipple discharge.
Right.
The nipple discharge, really, what I get worried about is, any nipple discharge for the general population is we should investigate, but the ones I get worried about is ones that is unilateral, meaning it's one breast, uniductal, meaning it's one hole in pore in the nipple, if it's clear or bloody.
Bloody, yeah.
You can also have normal nipple discharge, which can be green, gray, brown, weird colors. I know that doesn't sound normal, but it is actually normal, because behind the breast itself, you could get a bit of dilation of the ducts, where you get a bit of stasis and bacteria can grow, and you have various elements of liquids that can be produced.
You have the unusual cases, and you have women who've just had a baby, they're breastfeeding, and they just don't realize that they have a lump there.
Yeah.
So what would you advise those women?
Again, any lump, we were more stringent at a later age. I would say above the age of 25, any lump we should investigate. The principle, what we call is triple assessment.
Yep.
So a history, an examination, radiological investigation, be it a mammogram, an ultrasound scan, and a tissue diagnosis. I really, really think that if you have a lump, and a lump that is within during the period of pregnancy, there's something called pregnancy-induced breast cancer, which can happen during pregnancy, or it could happen even after 1 year after delivery.
Okay.
And again, pregnancy is a state where the body produces more estrogen, more progesterone, and all those things as well. So it actually could potentiate the cancers to be even a little more difficult to deal with and more aggressive.
So you mentioned some investigations there. You had the mammogram and the ultrasound.
Yeah.
A lot of women don't like the mammogram.
Yeah.
They find it painful.
Yeah.
So when do you choose which investigation?
So the standard of care and the only recognized tool for screening is mammography. Yeah, we have different types of mammography, but the standard of care for screening is mammography. So generally, it's patients older than age of 35. It's based on the principle of what mammography is. Really, it's an X-ray of the breast. The breast tissue, which is glandular, tends to be white. And as you get a little mature, the breast evolves from glandular to fatty tissue, which is black. So it takes pictures, and you get to see the abnormalities in the background of the more fatty breast tissue.
Right.
So patients above the age of 35 tend to get mammography as screening tools. However, if we have to do any breast imaging under the age of 35, we tend to push more for either probably a breast ultrasound, because again, it's difficult to see through the breast with the dense glandular tissue, which you tend to see in a patient under the age of 35. So the imaging modalities, if we're speaking now, we're not focusing on screening, is you have breast mammography. The 3D mammography is actually a nice new tool that we have for dense breast tissue, and that's a new machinery in terms of mammography that will help us to determine lesions within that background of dense glandular tissue.
And Medical Associates recently acquired a new machine, so it's available in Trinidad and Tobago.
Awesome. And it's actually the recommendation guidelines now. So when you talk about mammography, we don't talk about the old mammography machine, we talk about 3D mammography now.
Right.
Yeah.
And it gives you such a nice holistic picture.
Nice. It's really good for dense breast tissue. And then you have MRI of the breast. MRI of the breast is very specific for patients with high risk, patients who have a mutated gene, a BRCA gene, a risk of breast cancer.
So family history.
Family history, strong family history. Those are the patients we tend to push for MRI. And then we have breast ultrasounds, and then we have some new other tools that are coming up. But those are the main
Well, apart from just looking at
investigations.
the breast, let's say we found a cancer, we have to stage that cancer.
Yeah.
And you really want to push the
Yeah.
staging
So,
investigations.
so once you have a cancer, as I teach my medical students, the next step is staging. What is staging? Most of the time when patients come, the first thing I do is they come with me with a report and they say, I have breast cancer, and they see this thing called grade 1, grade 2. And they always think I have stage 2 or stage 3. The grade and the stage are two different elements when you look at the report. And these are things we will discuss when you come in the office, but grading is just how it looks under the microscope and the nature of the cells. But staging is important, because staging tells us the size of the lesion, the size of the tumor. It tells us if the lymph nodes or the glands under the armpit is involved, and if the other organs are involved as well. Again, CT scan is available at Medical Associates, where we can do our screening as well. And it's a chest, abdomen, and pelvis with contrast. So we look at the chest to see one of the common sites where breast cancer likes to spread. We look at the liver, we look at the bone. And sometimes if we do have to do it, if patients present with more advanced disease, with, probably neurological deficit or what have you, we sometimes do CT of the brain as well.
Okay, so we have touched on the presentation, and I think we should talk about treatment. But just hold on.
Yeah.
We're going to go for a quick break, and after we come back, we'll talk about the different treatment options available. So stay tuned.
Good day, my name is Dr. Laurent Olivier. I'm a breast surgical oncologist. Today we're going to talk about the breast mammogram machine. This is a tool that we utilize for breast cancer screening. It's the only recommended tool for breast cancer screening. Previously we used to use an older machine. Now we use a digital mammography machine, and we actually use this awesome machine, which is actually what we call a 3D mammogram machine. Allows us the ability to take views of the breast at various angles, as you can see how the machine is moving left or right, and allows the computer to reconfigure a picture, a 3D picture of the breast. This allows us to pick up 25% more breast cancers and allows the false positive rate to be reduced by 15%. What that means, the ability to pick up abnormality is actually more accurate than the previous mammogram machines. This machine is readily available at Medical Associates, and the standard of care, which is mammogram machines for screening, is now starts at the age of 40. This particular machine is a 3D mammogram, so it's tend to use in patients who are younger, within the age between 35 to 40, but the recommended screening of age 40 or so, it allows the ability to pick up the breast when it's significantly dense. The breast is made up of fatty tissue and dense tissue. The more dense it is, it's more difficult to pick up abnormalities. With the 3D mammogram, it allows us the ability to pick that abnormality and diagnose patients for breast cancer. Again, readily available at Medical Associates, allows us the ability to do our screening and diagnostic testing. Thank you.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high-quality, convenient, and fast scans. We guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back to Medical Associates Health Check. Before the break, we were talking about breast cancer, how it presents, but we know this is the part you're waiting for, the treatment. So, Dr. Olivier, let's talk about treatment of breast cancer.
Well, the treatment of breast cancer really, from international standards, what we practice at Medical Associates, it's a multidisciplinary approach.
Of course.
So we have a medical oncologist, we have a radiation oncologist, and then you have myself, which is a surgical oncologist, and then the team of the radiologists and the nurses in care and the patients themselves all become an integrated team to make decisions for the patient.
Mm-hmm. And the importance of family support with these patients.
Yeah, it's an important aspect of any sort of cancer, not just breast cancer, to have that support and that mental support to go through the treatment and some of the effects of the treatment, be it surgical or medical oncology aspect of things. So it is an important angle as well.
Yeah, I'm glad you touched on that, because women love their breasts.
Yeah.
And to tell a woman, to lose a breast is sometimes come like a blow to them. I could tell you, because like I say, it's something I dealt with personally with family and stuff. Yeah. And that's probably one of the hardest things to convince them that you might have to lose your breast.
Yeah.
But thankfully, there are new treatment options, so that even though we're treating a cancer, technically you don't have to lose your breast, right?
Yeah. So it's not really a new treatment, I would say. It's really one of the main things that I want to do over the next 20 years, in not just treating patients, but training surgeons coming forward, is to change that dogma, that thought process that if I have breast cancer, I have to lose my breast. So it's more of a refinement in technique. So, you have treatment techniques where you can either preserve the breast or remove the breast. At least 80% of my patients, I will preserve the breast. There are certain scenarios where I will remove the breast, and then we'll talk about the treatment options for those. In terms of removing the breast lump itself, which we call breast conservation surgery, we use a technique called oncoplastics. We use oncology techniques, wide resections of the tumor. Then we use plastic techniques to recontour the breast and maintain shape and symmetry of the breast. Most of my scars, I try to hide them. Either I put it under the armpit, under the breast, around the dark area, the nipple. Again, scars bring back memories, and memories, again, bring back pain and hurt of the diagnosis. Correct. So trying to hide scars as well as minimize the defect in the breast itself is important, but it's also important to get good oncological resection of the tumor. So it's really a refinement in technique. In the past, we would have just removed a lump and then go for treatment. I really, really try as much as possible to hide my scars. The other element, the patients who we have to remove the breast are patients who have like multiple cancer areas in their breast itself, where I will actually have to remove the breast tissue. And then if there's actually an element of the breast cancer within the skin. So there's something called like a pudorant, which we call inflammatory breast cancer. Those are the ones we can't preserve the breast. There's immediate reconstruction.
Right.
So where you can do reconstruction with either you can use alloplastic, which is things like implants, or we can use the body's own tissue. Yeah, and that's the two main types of reconstructions. And even more awesome is what we call a nipple sparing mastectomy, where you save the nipple, and then what you do is remove the breast tissue and you put in an implant. And that gives you a good outcome.
So you have some patients that have their surgery one time, and you have some patients that wait. What's the indication for either?
So it depends on your presentation. For example, if patients have locally advanced breast cancer, they have inflammatory breast cancer, we tend to do the mastectomy up front, and then we do a delayed reconstruction. And then most of my scenarios, I prefer to do immediate reconstruction one time because it gives you a better cosmetic outcome.
Okay.
Yeah, so that's what we call immediate, where we'll actually put in either a balloon first, which is an expander, or we put in a permanent silicone implant one time.
So there are patients, I don't know about in Trinidad, but certainly around the world, where you've had patients that have had breast cancer, had an implant placed, and then had subsequent breast cancer. Can you speak to that?
Yeah, so it's a type of breast cancer. I had one case, I think it's the first in the region. It's actually a patient that had a surgery done in Dubai about 8 years ago. She had breast cancer and she had reconstruction with what we call a textured implant. How she presented with a sudden expansion in the breast with a significant fluid around the implant. And that's what they call breast implant anaplastic large cell lymphoma. So it's a lymphoma. It's a type of cancer, not the regular type of breast cancer that we see. It's a lymphoma, more of like a blood cancer kind of way. But it's a cancer that was found in the breast. And the treatment for that, again, is removal of the implant.
So these implants are still in use now, or have they phased it out?
The general consensus, at least in my practice, I don't use textured implants anymore. All I use is wrong, smooth implants. The expanders and the balloons are textured, but they are for temporary. That's for the two-stage reconstruction. But yes, I think we are phasing out from textured implants because it stimulates the inflammatory response, which leads to the lymphoma.
Yeah.
So what new procedures are there? You said things are not new. It's more of a refinement.
Yeah.
But, there's always something new.
I think it's about principle. What we're trying to do is less surgery, for example, in the armpit. One of the main elements of staging the breast cancer is looking to see if the cancer is involving the lymph nodes. So we tend to do less surgery there now. We do something called a sentinel node biopsy, where we inject the breast with a certain dye and sometimes some radioactive substance, really to localize that lymph node, so reducing the damage to the area and obviously the morbidity or the complication that may arise from the surgery. But the mainstay one really, again, is the reconstructive element in nipple sparing. There's one of the issues with nipple sparing and all those surgeries is sometimes you may lose some of the sensitivity to the nipple. And, the research now is really trying to find ways of putting nerve grafts back to the nipple to reconstruct the nipple. But we're not there as yet.
Some women is always about worry of, this cancer coming back after I spend money to do a surgery.
Yeah.
I take chemotherapy, I do radiation, and bam, 2 years later, it come back either in the same breast or it come back in the opposite breast.
Yeah. So again, this all stems to what stage you present. If you do your screening, you pick up the cancer early, smaller tumor, greater chance for cure, then your recurrence rate is less. But there's also a nice new element in breast cancer now where we personalize management. Each patient is personalized. So it's based on the receptors or the type of cancer you have, and we know the behavior. We know certain types of cancers like to come back in 3 years. And those type of cancer, we tend to send to the medical oncologist first, which is available by us again, where we'll actually give chemotherapy first sometimes. And that helps the cancer to actually, what we talk about is what a complete pathological response, where the cancer actually disappears.
Right.
So that's what we want to achieve. And that's where the personalization. And that's why you need to go by someone who can personalize your treatment. Don't do the old dogma of just removing the breast. Each cancer is individually treated. So we have cancers that like hormones, we have cancer that don't like hormones, and we have cancer that has a certain receptor called HER2. They all behave differently and they all manage differently. Some may be upfront surgery, some may be treatment before.
You have men that also present with breast cancer.
1% of all breast cancers are male breast cancers. Yeah, and once you have breast tissue, there's a propensity for you to get that tissue converted into cancer.
So is there anything you would suggest that they do that's different to screening for women, or screen the same way?
We don't screen for male breast cancer, it's just clinical examination.
Okay.
But if we do have a male in your family who have breast cancer, then that's an indication to look at your genes.
Okay.
Yeah.
And in terms of like the breast, is like a more fatty breast or fatty male breast, is it at a higher risk than, let's say, a muscular chest guy?
Yeah, I wouldn't say the fatty breast tissue, but is the amount of breast tissue. You know, so I wouldn't say if there's have more, what we call more breast tissue, you have an increased risk, obviously, but it depends on the breast tissue itself converted into cancer.
Right. Okay. So, Doc, you know, like, I don't know, there's a touchy topic, no pun intended, but we have globally where, you know, transgender is becoming a thing, right?
Definitely.
So we have patients who are converting from male to female, and likely female to male too. And that comes with a lot of hormonal changes, hormonal medications, and there's still a theoretical risk of they having breast cancer.
Yeah.
So what's your perspective on the screening for transgender patients?
So we know that hormones itself, be it from your own body's production or you're taken from outside, that increase your risk of breast cancer. So men going to women, there's a small increase because they're going to take supplemental estrogen therapy or hormonal therapy, which will increase their risk. Again, it wouldn't be necessarily that you have to do mammography, but definitely clinical examination will be warranted.
Right.
And then women going to men, they still have breast tissue. So they still need to do the protocols of screening, which is the annual screening from age 40 and above, which is the only screening tool, again, is the digital mammography.
So we also have women that have breast implants for cosmetic reasons or with plastic surgery. What's the screening process for these women?
So it's the same mammography again. What they do to the radiologists, and they have a special technique where they will actually compress the breast and push the implant backwards.
Okay.
So the breast, so you have different ways on different sites where you put the implants.
Right.
So you can put the implant just beneath the breast tissue, or you can put the implant beneath the muscle. The standard of care now, what I practice, is dual plane, where we go beneath the muscle and we release the muscle a bit and let the breast tissue fall over the implant inferiorly. Again, with the mammography, you can actually compress the implant posteriorly and you can still see the breast tissue in front. So you still need to do your screening.
So it's really important then for women to know what type of implant they have or what type of technique is used.
It's important because, again, we need to know where the implant is placed.
Yeah.
And also it's important just to know what surgical procedure you had.
Yeah.
In terms of the contraceptive pill, I mean, many women do use contraceptives for, you know, just as a routine.
Yeah.
You know, does that confer increased risk for those patients in terms of breast cancer?
So again, we know that breast cancer is associated with estrogen and hormones. There is a transient risk, and a mild transient risk is always described. I'll explain. Transient means that if you discontinue the OCP within a period of 10 years, the risk is gone. It's mild because it's very minimal.
Is that because when you've been taking it for 10 years and discontinue, or is it 10 years after you stop?
So once you discontinue it,
Right.
you have a particular risk. But after 10 years, it gradually decreases. And that
Okay,
10-year
fine.
period, after you discontinue the OCP, the oral contraceptive pill, then the risk is totally no longer there.
Okay.
And that is similar to as well in hormone replacement therapy. So patients who in menopausal and they have symptoms, there's a risk as well
Yeah.
for breast cancer associated with it. What we found, so when I used to work more in the rural areas, a lot of the culture is that patients hide things.
Right.
So a lot of the various traditions is that they wouldn't tell their daughter, wouldn't tell their sons, and they will come to us with this fungating mass. So really and truly, it's just about being aware and alert and bring
Correct.
awareness to patients to let them know that there are treatment options. And don't be afraid. You know, we can definitely do a lot of awesome stuff now. Again, if we pick the cancer up, we can have cure, and then definitely we can salvage and save the breast as well.
Good. So, I mean, Doc, thanks a lot. I mean, you shared a lot of information. So there you have it, guys. On today's episode of Medical Associates Health Check, we would have discussed breast cancer. If you wish to see this again, you can check us out on our social media pages on Facebook, YouTube, Spotify.
Yeah.
I mean, it's really a topic that, I mean, many women, I'm sure, are really happy to have, you know, spoken about in such great detail, you know.